So the background to what I want to say is, well, first of all, to say that we've actually made extraordinary progress in cardiovascular disease, and the reductions, there's been progressive reductions in cardiovascular mortality, which have been the major reason for the reductions in overall mortality and increasing in life expectancy in most Western countries, including New Zealand. So we've done pretty well, and the question is why. So lifestyle factors, some have clearly improved. Smoking has gone down. We're certainly a lot better at diagnosing cardiac diseases early and in treating them. But the real focus of this talk, and I think where primary care is so important, and probably the biggest overall improvements have been in the secondary prevention, the management, chronic management of cardiovascular disease, and the reduction in the risk of future events. So this is the American Heart Association. We hear all the New Zealand stuff all the time, but this is the American Heart Association Life Simple 7. So the 7 things that they say that we all should be doing to reduce your, improve your longevity, reduce your risk of cardiovascular disease. So that's having a good blood pressure, taking regular physical activity, maintaining cholesterol level at a satisfactory level, having a healthy diet, having a healthy weight, not smoking, and having an okay blood glucose level. Now this is the results from one of probably one of the biggest and most important studies in cardiology from an epidemiological point of view. This was the Interheart Study, where they looked at, across a number of countries, they looked at what were the risk factors for a person having a heart attack compared to people not having a heart attack. And there's a few abbreviations down the bottom which I apologise for, but it looks at on the scale up the side as the odds ratio for having a heart attack. So there's smoking, diabetes and hypertension, and a high ApoA1 ratio, sort of basically LDL or total cholesterol HDL. And all those things increase your risk of having a heart attack by 2 to 3 times if you have them as opposed to you don't. Now the point I want to make though is the real risk comes when you have several things together, so that you have a multiplicative increase in risk as you have more risk factors. So if you have 1, 2 or 3 of those things, then your risk goes up 8 to 16 times. If you have all 4, it goes up 32 times. If you add in obesity, it goes up further. And if you add in psychosocial stress, it goes up further again. So this is important, obviously, in terms of understanding how multiple factors combine together in a kind of multiplicative way to increase the risk. It's also relevant to the strategies we need to think about in terms of reducing the risk. So we don't just think about one thing. We need to, at an individual level, look at what can be done across all these things potentially to reduce the risk. And this shows, well, we sort of know the importance of lifestyle, but this is measuring 4 simple lifestyle things. You don't smoke, you have a modest or no alcohol intake, you take regular physical activity, and you have a healthy diet. Well, if you do none of those things and you're 50 years old, you have a 25% mortality over the next 14 years. And if you do all of them, you have a 5% mortality over the next 15 years. So you can see there's huge differences in mortality over the longer term, I guess, by the cumulative effect of lifestyle things which are present in middle age. Of course, those things would have been present for the whole of the person's life, most of them, so there's a cumulative adverse effect. You can't necessarily reverse it all. And we know, and again I apologise, this is US data, but I'm sure it's pretty much the same here, if when we look at these 7 things that are driving risk at a population level, the green is when it's achieved and the red is when it's bad and the orange is when it's intermediary. You see that there's a population level as these adverse factors are incredibly high, and so you get sort of immune to it almost, the burden of risk. So current smoking about 20% in America, that's probably slightly lower here. Rates of obesity are very high, as we all know. Rates of not doing any physical activity, very high. 50% of the US population, probably not too dissimilar here. 80% of people have an unhealthy diet according to their healthy diet score there, and then smaller proportions who have don't reach the thresholds for those other things. So physical activity, the current guideline, the standard guideline is that you should do 30 minutes of moderate or vigorous physical activity on most days a week. That's kind of the standard international guideline that's out there. But there's a number of studies recently that show that actually, well, first of all, most people don't, a vast majority of the population don't do that. But secondly, actually even lower levels of physical activity are important. So, for example, if you have, like I unfortunately do, a job where you might sit at a desk for a number of hours a day, you do too, and then you get in a car and you drive home to work, and then you sit in front of the TV, you are sitting for more than 8 hours a day. So sitting for more than 8 hours a day, irrespective of everything else you do, is associated with a 30% increase in mortality. There's large population studies that are showing that. Now this graph is shown from a work that I was involved in with physical activity in a large population with stable coronary artery disease right across the world. And you can see what it's trying to show here is that there's a steep reduction in mortality going from not much exercise to increasing amount of exercise. And those lines represent about 50 is the sort of 40 to 50 is the sort of the average, I guess. So most of the benefits, there's a huge association at least between modest increases in physical activity at the low level and risk. And once you get up to doing a pretty reasonable amount of physical activity, the line is almost flat. So there's not huge major gains by going from reasonably regular physical activities to going to high levels. So the biggest benefit from our patients, I think, is getting a complete slob to do a little bit, and then a person who does a little bit to do a little bit more. And my view is, with physical activity, is that it really has to be individualised. But if you can get people to do even a modest amount more than what they're doing now, there are potential gains. So now we're moving on to hypertension, and one of the very interesting studies that was reported recently was related to salt. So for many years we've known that there's an association between how much salt you have in the diet and what your blood pressure is. And this is a result of a very large study where they looked at that across multiple populations and 100,000 people around the world, and they show, as we know, that there is this greater association between salt and blood pressure. So the rationale has always been we need to reduce, there's too much salt in our diets, there's all this processed food full of salt, and we need to reduce the salt. And also the rationale has been, well, we need to advise salt reduction for blood pressure reduction. But one of the very surprising results of the study is when they looked at the amount of salt excreted in the urine every day. So that was basically a measure of how much, I suppose, excess salt there is that you take in the diet. That's the more you pee out, the more salt there is. And there was actually this U-shaped relationship. I'm not sure if I've got a pointer here, but if you look on the left-hand side of these plots, you can see that that blue line goes upwards, and that's an increase in risk of cardiovascular, major cardiovascular events as your salt intake goes down low. And this salt intake was all within the recommended guidelines. So in fact, you're better having about 3 times as much as the recommended guidelines according to this association, that actually reducing the salt is increasing the cardiovascular risk, even though the blood pressure is slightly lower. So this is thought to be due to neurohumoral activation. So we know from many studies in other cardiac situations, heart failure is the classic, where the more neurohumoral activation you get, so the more activation of the aldosterone and angiotensin and you get, the higher your cardiovascular risk. And it could be that actually reducing the salt in the diet actually is one way of promoting neurohormone activation. That's the hypothesis. That's been controversial. I'm sure that Bruce probably might have a different view. So this is another study, the SPRINT trial. I know that Bruce is also going to talk about this as well, because it's very striking. So the standard guideline is that basically, you know, if you're treating blood pressure, you should treat to a blood pressure of 140 systolic. You know, if you get the blood pressures mostly below 140, then that's pretty good. And if you go lower than that, then you'll probably just get side effects and complications related to the treatment. So this trial took people who had high cardiovascular risk. They excluded people who have diabetes, mainly because diabetics, the thought is that they actually should have a lower blood pressure. There's other studies that show that, you know, they have a particularly high risk and their blood pressure should be low. So they had two targets, one of 120, aiming for less than 120 millimetres, and one for less than 140. And this is what they achieved. They certainly achieved a difference in the systolic blood pressure between the two groups. You can see on the one hand it's about 135, and on the other it's just above 120 in the separation of the groups. And that was achieved by, on average, just under 2 medications for the more conservative strategy, and just under 3 medications on average for the more vigorous strategy, so about 1 medication more. And this is what happened to the cardiovascular events over time, and what you can see there is that the death from any cause on the bottom, and the primary outcome measure of cardiovascular events, a combination of cardiovascular events, they're both lower and significantly lower in the red line there, which is the more intensive treatment group. And I guess when you're looking at these, you've got to, Diana.
Right, just trying to, what age were these people, and also did they do any quality of life measures between the two groups?
The age is in the low 60s. I mean, Bruce might be able to give me a more accurate answer.
I'm going to talk about the over 75. So there was a range of ages, basically, but they're all at very high cardiovascular risk. They'd all had an event. The 10-year risk was 25%, so it's pretty massive. So there was quite a range. So this is the results for everybody. I'm going to talk about the over 75s this afternoon.
So the side effects are interesting. There was a higher rate of side effects, but it wasn't that much higher. And I guess it was trumped by the, you know, well, mortality is the ultimate adjudicator, I guess. So the rate of side effects, so the particular concern, for example, would be that symptomatic hypotension would be greater, and that is true, it was slightly greater, but it was not dramatically greater. And I think that comes back to an individualised approach. I mean, my view is you probably take things gradually and look to higher doses, but obviously you need a treatment regime that's going to suit the individual person well.
Rafe, I'm a big fan of chlorthalidone, and that was the one they deliberately chose for that drug because I think the Americans are realising chlorthalidone works and hydrochlorothiazide probably doesn't, or is less effective. Do you, are you in my camp on that one, or do you use it?
Well, I use it. I'm in the camp of I'm not quite sure, need to be educated. So my understanding is that there is observational data that shows that the outcomes are somewhat better with chlorthalidone, but I would need to be educated on the pros and cons of the different.
Well, in the ALLHAT trial, it was as good, if not better, than amlodipine and lisinopril. But only about 7%. Most people in New Zealand use bendrofluoride, about which there isn't very much evidence. In fact, we've got an article coming out in the Journal of Primary Healthcare saying there's plenty of evidence around chlorthalidone and indapamide, and actually just about none around bendrofluoride, other than when it's in combination with something else. So we may be using the wrong diuretic in New Zealand. So join the chlorthalidone club, folks. So.
I've just got a question about that previous graph that you showed. The number at risk at the bottom, if you look at that, that's actually not that different between the two groups.
Yes, no, that's very true.
At the end of the trial.
Yeah, no, that's true. You are looking at that's very true. So what I'd say to that is that so the absolute benefits look relatively modest, and that's definitely a consideration. But one of the things is these trials are all relatively short. I think the average follow-up of this trial was about 2.8 years. I'm not sure of the exact number. And I think that most of these treatments are given over a long time. So, we're looking, when you're giving a middle-aged person blood pressure medication, for example, the actual benefits that you're talking about are over the next 20 years, even though we tend to think in smaller periods of time. And if you can get a regime that suits the person well and reduces risk over, if their risk is high, I mean, I think this comes down to what their risk might be. If the risk is low, then you could argue whether that's a useful thing. The higher the risk, I think that my view would be that probably the simplest thing you can do to reduce your risk is being on proper medication, and trying to achieve that is something we should strive for. But those risks, by their nature, are small when assessed over the short term, but accumulate and become substantial when you look at it over a longer period of time. And that applies to statins as well. You get substantial benefits that accumulate over a 20-year time frame, which may not be evident over 1 year. But if I looked at myself and said, well, as I do this strategy and I have a 1% less chance of dying this year, well, I say, oh, well, I'll take the risk. But then you add that up over the next 15 years, it adds up to sort of 20%. Then I'll say, oh, well, actually, I'll do this simple treatment to reduce that risk. That's the way I think of it anyway.
It's flattened out between 4 and 5 years.
Yeah, I think that the problem there is that there is low numbers, so that the trying to judge those things becomes a bit suspect at the far end of the curve because of the low number of events out there.
Yeah, the trial was stopped at 3.2 years, so not a lot of people wouldn't have got that far through, so that's why the numbers peter out at the end there. But if they kept that trial going, then it would look like this after 20 years, so your absolute benefit would be considerably higher.
And that is one of the big problems, I think, with these studies, is that you're really looking, I think universally we were looking at treatments that we would normally give over many years, which almost certainly have cumulative benefits over time, and then you're trying to judge the benefit over a short period of time, relatively short period of time, because the studies can only be done over short periods of time.
Sorry, just a question about, maybe not related to this trial, but there's a patient, 24-year-old. He has high blood pressure, family history not very, his mom died, they don't have high blood pressure, but we gave him like, I just seen him after maybe 3 months from treatment, and apparently when he went to the hospital, they gave him triple medication immediately for high blood pressure. Then I saw him, I found his kidney started to get, creatinine high, so I stopped one medication, and still his blood pressure is 120/80 or 70. But my question actually, is it now the trend is to start a very strong blood, especially young, triple therapy and then reduce, or you start slow and go low? What's now the trend for treatment of high blood pressure?
I mean, in this case, it seems a crazy thing to do. I mean, to start triple therapy on a 20-year-old whose absolute risk related to the hypertension would be extremely small in the next 10 years. And you've got a significant chance of side effects if you whack them on 3 drugs straight off. So I think that in his case, well, you've already answered one question, was it the circumstances on which he was in hospital that was the reason why his blood pressure was so high? Yes. Yeah, but even that might, I mean, there might have been something related. The fact that he had a high measurement, and that's one, I'll talk to that in a minute, but that is a warning, even if at other times the blood pressure is low. My view is that but you can afford to take time, and the patient obviously needs to they need to understand what the issues are as well. I mean, they're the person who has to take the medications for God knows how long. So, they need to understand that we're talking about long-term risk, that any benefits they get from the blood pressure medication are likely to be extremely small in the first 5 to 10 years, but we're looking at a cumulative benefit. We think it probably has favourable effects on your heart, arteries and your kidneys and your lungs cumulatively over time, but your actual absolute risk of having any adverse event related to the blood pressure in the medium term is extremely small. And so I think, you can afford to take your time. There's not a need to rush onto medication. You need to multiple measurements to find out what they're on, and then take your time to make sure that you get probably the most important thing is to get treatments that are convenient and well suited and don't cause an issue. But if you genuinely have a blood pressure that's very high in your 20s, then you're looking, you might not have a high medium-term risk, but you have a very high risk in the long term. And I think some sort of discussion around treatment and in the long-term perspective is appropriate. So this leads on to the next interesting thing, which is the importance of variation in blood pressure from one time to another. So we know that if you measure the blood pressure on 2 occasions, even at the same visit, you might get a different result. If you look at a 24-hour blood pressure monitor, you'll easily get quite a lot of variation. You get, a quarter of the measurements are high and then other ones are low, and often I've been inclined to be guided by the average measurement. You often say, well, is the patient's measurement high just because they're coming to see me? The doctor's a white coat hypertension, and then if I get multiple measurements, if I get a low measurement, I'll be reassured by that and don't have to do anything. So the question is, does this variation in blood pressure, how should we interpret that in terms of the treatment, and should we go for the lowest measurement or the highest measurement, or the average? So there's a number of studies now that show that actually...
Can I ask a question? Is there a theory yet on why the variability throughout the day?
There's a theory that would be that there's a combination of factors which can influence the blood pressure more than just the diurnal variation. I mean, we know the blood pressure goes down when you sleep on average, presumably because the brain has a major impact on what the blood pressure is. It's influenced by psychological factors. It's influenced by the state of the adrenergic system. Multiple factors can influence the blood pressure. That's not a very good answer, I know, but there are multiple factors which are involved in the control of blood pressure, which can be variable or more constant. So anyway, there's a number of studies now that show that after accounting for what your average blood pressure is, the amount of variation is prognostically important. So the more variation you have, it usually measures the standard deviation of your blood pressure's measurements, which is not very practical when you're in the clinic trying to work out a standard deviation, but even the maximum to minimum would be one measure. But the more gut feeling is, the more it varies, that actually in its own right is prognostically important. Now, to my knowledge, we haven't gone to the next step of saying, well, should we, what happens if we guide our treatment, basically use that as an indication for treatment? Do those people do better than the average? So that trial hasn't been done, but my view would be that if you're on the grey zone of whether to give a blood pressure medication, we shouldn't be ignoring all those high measurements. It's the practical thing to do is to say, well, I'm on the grey zone, I've got these high measurements, then we know that variation in its own right is associated with risk, and it makes sense to do it, rather than the other way around of saying, well, I've got this one measurement here of 130, I'm reassured by that, and therefore all the others I'll ignore. So I was going to move on to statins. So I know this is probably one of the biggest sort of different gulfs between primary care and cardiology department is the statins. So I'll give you my perspective, and then you can give me yours. So one of the first things is that we've got this huge body of data. I don't know. I think is it 200,000 patients have been randomised to the various statin trials, and so that we know that it reduces. If you look at all the data together, it's pretty clear that every 1 millimole reduction in statins, you get a 1% reduction on average in cardiovascular events right across the board. And then there's statistical power as to whether that's significant in individual studies. Now, one of the really surprising things, it doesn't quite make sense, is that the benefits of the statins seem to be completely unrelated to the level of your LDL cholesterol to start with. So you think, well, if your cholesterol is high and you've got a drug that reduces it, then that would be, you get more benefit than if it's low and you have a drug that reduces it. But this is an example of what the hazard ratio for mortality reduction according to what the LDL cholesterol was when you're in it, and you can see that they all line up pretty much in a line. In other words, the hazard ratio of the reduction is just about the same right across the board. So that means, even though it's kind of hard when you're talking to the patient to explain this, the bottom line is it's beneficial to be on a statin. Doesn't really, if you've got to reduce your cardiovascular as a risk point of view, which is what we're trying to do, it doesn't matter what your cholesterol is. So we really think of the lipid or the cholesterol level as a risk factor. So it is true that your risk is higher if the cholesterol is high. But if you've decided the person's got high risk, then we shouldn't be focusing on the LDL cholesterol. The greatest benefit of the cholesterol LDL is to tell you whether the patient is taking their medications or not. It's the one best way of finding out is just looking at the LDL cholesterol. That'll tell you whether they're taking the statin or not. So then the next thing is, well, what about the benefit from, is more better? And I think we've got very good evidence that is the case. So we've got 5 clinical trials where they compared a bigger dose of statin with a smaller dose of statin, and all of them said the same thing, that the reduction in risk, so over the 5 trials, is about, depending on which way you look at it, is about a 20% reduction if you use a higher dose of statin compared to a lower dose of statin. And this is just one of those trials, and it comes back to the point made earlier. This is comparing a torvastatin 10 milligrams with a torvastatin 80 milligrams in a very large cohort of people who had high risk. And what you see is that there's a 22% relative risk reduction. Now, the key thing, the point was made earlier about the absolute risk reduction. You see that it goes down, but that's over this 5-year period, about 7% absolute risk of a major event, and that's gone down by, so 1 or 2%. So basically you'll get, but you see there, you can see the line basically is showing what's happening over time, so it's almost a constant excess rate that is cumulatively going over time. So these curves, because it's a reasonably large study, and if it's the same with all of it, you're just moving the person down to a lower risk or rate of cardiovascular events, either by being on statin, which accumulates over time, or being on a higher dose compared to being on a lower dose.
What about the side effects?
Yeah, well, that's right. So that's the key thing. So I quite agree that the key concern is you're giving drugs that cause side effects. Now, the really bizarre thing is that there's this huge disconnect between the side effects you get in the trials, where people don't know what they're taking, against the side effects in real life. And the side effects in real life are much higher. So in the trials, the muscle ache risk is about twice as high as in the placebo group, but it's about 5%. And in real life, it's about 20%. And then the other thing that's what I was struck by was when they did the new trials. I'll come to in a minute on these new group of cholesterol-lowering drugs. They wanted to get people who were intolerant to statins. So they said, we want to prove you're intolerant to statins by the run-in period of the study. So they gave them a placebo, and they all got the side effects. At least the side effects were very high. And then they give another group the statins, and the side effects were almost the same. So what I think is that the clinical trials, which are absolutely enormous, they show that there is a modest rate of side effects. But I think there's also a tendency to ascribe symptoms to the medication. And if you have a symptom like I'm forgetful, I quite often get that. Well, if I can blame it on the medicine, that's absolutely terrific. I'll blame it on the medicine. That's all out there in the literature. Everybody knows about. I'm a bit forgetful. I don't want that. And certainly the cognitive functions, another thing. People are legitimately concerned about any question of a drug that might affect their thinking. Right, don't want to take those. There's actually, they did a cognitive function test on one of the huge statin trials and found absolutely no difference. So I think, my view is that there's a lot of, it's just the nature of the human condition, isn't it? The influence, the things we respond to. But I think that there's the evidence from the randomisation when people don't know what's happening is very reassuring in relation to statin side effects. It's not to say they don't happen, but I think the risks are lower than and in these trials of the high dose versus low dose statin, the side effects were not significantly different, surprisingly, not significantly different.
So just on that, could you comment on the increased rate of diabetes with statins and how relevant that is, please?
Yes, so that's, it's poorly understood the exact mechanism, but it is true that the rate of diabetes is slightly higher on statins than not on statins. Now that, however, despite that, the rate of cardiovascular events is lower. So in other words, that's a sort of concern, and it's a legitimate concern, but despite that, strokes are less, heart attacks are less, things that actually, in the end, diabetes is a blood test, isn't it? That's what it is. So all the hard events, the stuff that actually happens to patients, is all better on the statin. So my view is that while statistically there is a higher rate of diabetes, it's not the reason not to use them, including diabetics.
It's the same with the diuretics. They increase the risk of diabetes, but the cardiovascular events are lower. If you treat chlorthalidone, increases diabetes, but you're still better off with the drug than you are with placebo.
We've got really strong social media and natural therapists against statins. And I'd have to say that probably 50% of my patients who should be on statins choose not to take them. You've run through two things. You've said we can have an increase in blood sugar levels. It doesn't affect cognition and dementia. Could you just take us through the commonly discussed in the media side effects of statins and affirm which ones are real and which ones aren't? Moving outside cardiovascular.
I actually think the one argument you can use for the patients is that they've looked at the relationship between media warnings of statins and cardiovascular mortality. So that happened in Australia and it's happened in Europe, where they've shown that the media warning, something splurge in the media about concerns about statins, people come off their statins and the event rates go up. So, I think that's pretty powerful. If I was talking to the patient, I would say that the risk of a heart attack, the risk of a stroke, the risk of dying goes up. It's lower if you take the drug, it's higher if you don't, and that we have no robust evidence that causes these side effects. But I absolutely acknowledge that we need to, if there's any question of side effects in your case, we can review it. That's the approach I take. And I don't know if I can argue against it's like trying to argue against Donald Trump, isn't it? You can't argue against every claim that's made. It's not possible.
Could you comment on the number needed to treat in primary prevention? Because I think that actually is the key issue in my way of thinking. So I think that one of the problems with statins is that it comes down to what your risk is. So if you've got a low risk, we know that the drugs will probably, if you take them, see the other thing is in these trials only about 25% of people didn't take the drugs after a while, even in the trials. So that diminishes the ability to detect the true effect. So if you take the drugs, we think there's it'll reduce your risk of major cardiovascular events by 40%. Now whether that's worth doing really depends on what your risk is. And I think that the reality is it's substantially lower in when somebody who's never had any cardiovascular disease, and certainly if you don't have other cardiovascular risk factors, it's low. So, and I think that's one of the problems is that certainly from my point of view, it's secondary prevention where the bang for the buck is. We're really concerned that 40% of people who have had a heart attack or had a stroke have come off their statin after a year. And I think that's been muddied by a whole lot of people who are recommended statin who actually have a low cardiovascular risk and would be fine without it. And I think that comes down to, you can do sort of complicated
equations on your risk, but it also comes down to what the person's view of life is, and what they think about taking a tablet every day. But I think that is key, and I think that there is a huge area of question related to primary care, but that should not translate to secondary care. That it should be pretty clear. Every single guideline is the same. It's recommended.
I had a gem I sent out last year or the year before on the cardiovascular calculator from University of British Columbia, which shows the smiley faces, and it shows you the percentage of people who actually get a benefit and then those who don't. And I have to say, I am really surprised when I'm doing, it only works for primary prevention, how rarely people are willing to take, like with, a 10% benefit, 10 out of 100 over 10 years won't take a statin. I've been really surprised for primary prevention. Things that I would take a statin for, most of my patients actually don't. And I think that's the only way, because you have to let them use their values. And I've got patients who'd spend $1 billion to avoid a 0.5% risk, and I've got other people who wouldn't, don't worry about a 50% risk. So I think I give the numbers to the patient. They can look at this picture. It's got smiley faces. They sometimes take it home. And I'm going to show a bit of it this afternoon, but if you remember the gem from a couple of years ago, it was called a really good calculator. And I'm hoping I've asked the Heart Foundation, when Rod Jackson's new equation comes in, to actually stick that in. Because actually what they're finding with the New Zealand equation, it's about a third lower than the Framingham ones. So actually the benefits you get in the New Zealand guidelines now are actually lower than so your patients are getting less benefit than we think they're getting for primary prevention, certainly, because the cardiovascular risk, as you say, it's gone down. We're not dying from cardiovascular risk anymore. So that's this afternoon. So if you come,
so that's not an answer, but it is an answer. In other words, I don't know about primary. I think it's a challenge to know where to draw the line, and I actually think that there's a lot of individual. It depends on the individual. For secondary prevention, I think the discussion needs to be different because the absolute risk is so much higher.
Sorry, just a question about, clarify one point here, about most of in the ratio when you use when we use cardiovascular risk assessment, we use the ratio. While here, most of the study, they use LDL. So can you clarify this point? Because
I thought it might have been my next slide, but so basically the ratio is used because if you want a single lipid measure that is most predictive of your cardiovascular risk, it's the ratio, either the ratio of LDL to HDL or total to HDL. And that's because the HDL cholesterol provides additional information on what your risk is. If it's low, it's higher. Now, as I'll say in a minute, well, maybe I'll pause and say it in a minute, but the problem is what do we treat? So what we treat actually is the LDL cholesterol, because that's where we've got the evidence that lowering LDL cholesterol lowers the risk. And so my view is that that's a very good question. It seems to me makes sense once you've put to focus on the thing we treat, and the thing we know relates to the medication the person taking, which is the LDL cholesterol. But that's the difference. It's the risk against what we treat.
Should we have an LDL to HDL ratio? Would that make more sense?
Well, I'll talk about HDL, but you've interrupted my train of thought. So this is just the mechanism of the LDL lowering. So we know that statins block HMG-CoA reductase, which is a key step in the synthesis of cholesterol in the liver. And then we've got another medication, ezetimibe, which blocks a receptor in the gut wall to block absorption of cholesterol. Now, ezetimibe results in a more modest reduction of cholesterol. It actually has an additional LDL, and it has a beneficial effect when added to LDL. It's kind of gone a bit because the one study that was done was on people who had started with really quite low LDL cholesterol to start with, and there was a benefit, but it was rather underwhelming in terms of magnitude. But nevertheless, I think ezetimibe is, but that study, which was of 19,000 people, showed that ezetimibe was very safe. So virtually no side effects. So, and then we've got this other, the new kid on the block, where there's a lot of excitement, at least in the scientific world, about these new drugs, the PCSK9 inhibitors, which work by a different way. And there was a trial that was just presented in the US and has been in the media, which shows that this drug reduces cardiovascular events. So it's quite an interesting story. So it came from the genetics. So they looked at populations who had higher or lower rates of cardiovascular disease, and they found that mutations in this particular protein, which either increased its function or reduced its function, were associated with higher or lower levels of risk. So they had no idea that this had anything to do with lipid metabolism or what it was doing until they did this. And then they said, well, actually, if we found this PCSK9, if we target an antibody to this to knock it out, then theoretically we will reduce the LDL cholesterol and lower the risk. So what this PCSK9 does is it binds to the LDL particle and the LDL receptor in the liver, and then when there's endocytosis, and then it knocks out the receptor, so it's not recirculated back onto the surface of the cell. So you have less LDL receptors on the surface of the hepatocyte, and therefore you've got less ability to extract the LDL, so the LDL levels go up. So if you knock out the PCSK9 with this monoclonal antibody, then the lipid levels go down. And the incredible thing is you can get the lipid levels down dramatically, so you can get the levels down. You can almost get them down as much as you want. So you can get them down in this trial to 0.5 millimole per litre was the level, so well under 1 millimole per litre. So that showed us two things. One is it was very safe. There's always been a concern of, what's the harm of getting the LDL cholesterol down to low levels, and maybe we should stop at 2. Well, the risk goes down the more that we lower the LDL cholesterol, and these drugs, which have a really dramatic effect on the LDL, they really get it down, and that doesn't seem to be shown any adverse effects. In fact, they did a cognitive function study, a separate study where they did detailed cognitive function testing on the patients who were on the drug or the placebo, and there was absolutely no difference over a 2.5-year period. So now it works as a monoclonal antibody, so it's given by an injection. It can be given, 2 weeks, 1 month, 6 months. It's a question of whether how often you need the injection. So it's kind of appealing. You could have an injection. You come and visit your GP once every 3 months or 6 months and just have the injection. Don't have to have tablets every day. But the problem with it, is we need more data. But the other problem is that because it's a monoclonal antibody, it's expensive. So you've got the diseases that, cancers, these treatments, antibodies are fantastic in cancers. To use it to treat a very common disease, to get the cholesterol down, it's an expensive strategy at this stage. But the story is very interesting. Now, genetics actually also helped us with the HDL story. So as we know, for years, we've known that HDL, the lower your HDL cholesterol, the higher the cardiovascular risk. So therefore, we thought based on this that, therefore it must be that if you raise the HDL, you lower the risk. So this is, a few $1 billion have been spent by the pharmaceutical industry with HDL raising drugs, and a number have been developed, and they've all raised the HDL. They all have absolutely no impact on risk. And then they went back to the genetics and they looked at genes that are associated with a higher or lower HDL cholesterol, and they're not associated with a higher risk. So HDL is somehow measuring, it's tracking risk, but it's not itself driving risk, if that makes sense. So, in terms of treating, I think we can give up on trying to do things to raise HDL cholesterol. When we do that, it doesn't help. All those drug niacin and bezafibrate and then the whole range of new drugs which haven't come to the market. It's really just a risk marker. So if your HDL is low, then or your cholesterol HDL ratio is low, then you've got a higher risk.
Rafe, 5 minutes.
5 minutes?
5 minutes.
Right, I'll have to go for the exciting bits here. So we'll just see. So one of the... So I think the other kind of, I think, is very interesting area is the impact of importance of psychosocial stress in the heart. And by that, it's a very loose term, but it means kind of anxiety and depression at an individual level, adverse life events and social isolation. And we've got quite a lot of increasing evidence that it's important. So one lot of evidence actually which is particularly striking is the impact of major catastrophic environmental events, so the Christchurch earthquake being one, missile strikes in Beirut, that these things, so if you look at the rate of adverse cardiovascular events in the day or two after these occurrences, they go up and then they go back down to the baseline level. So that suggestion is a clear link between an acute stress at a population level and risk. And that applies to acute myocardial infarction, so acute coronary events. It applies to atrial fibrillation, so atrial fibrillation got a whole lot more common with the Christchurch earthquakes. And it applies to stress cardiomyopathy, which I'll talk to in a minute. And then at a population level, the same applies. We'll just go over that. So this is, for those who haven't seen it, Takotsubo cardiomyopathy. So this is something we see, for some reason we virtually never diagnosed 5 years ago, and we diagnose it every day almost, or a couple of days now. I don't know whether stress in Auckland has gone up or what's happened. But this is this is condition. So basically somebody has an acute, severe, stressful event, either emotional stress, an argument or a learning of a death or something, or a physical stress, they fall over and get a car accident and smash up. And then that stress results in this blowout usually of the apex of the heart. So the apex of the heart blows out and doesn't contract. And that's why it's called takotsubo. So takotsubo is these clay pots that were used in Japan traditionally for catching octopus in the Seto Sea. So they used to drop these clay pots down. The octopus would crawl in through the narrow neck to sleep, I think, and then they just pull them up and be an octopus inside. So it was first described in Japan. It's sometimes called stress cardiomyopathy, but also takotsubo. So that's very common. And just from a practical point of view, so it's related to physical and emotional stresses, but from a practical point of view, it can cause a very severe left ventricular dysfunction early on, actually much greater than with an acute, on average heart attack. So it's like a big heart attack. So they might get short of breath, pulmonary edema, and arrhythmias early on, and then the left ventricle recovers. So, and it's halfway to recovering after about 5 days, and then it recovers back to normal after about a month to 6 weeks. Now, at this stage, we don't know how to prevent this, and we don't really know how to treat it, but it's, I guess it's important to recognise. So I'm not sure whether I should stop and I'll just see if there's any important things I was going to... Yes, there is a risk of recurrence. Pretty low risk, about, 1 in 20. I'm not quite sure how you handle that though, because we don't know that, for example, beta blockers, might be a logical thing, but the evidence suggests that they don't prevent it. So I guess people being aware of the risk is something, but trying to avoid stress is challenging.
Excuse me, can I ask a question, please, if you don't mind?
Sorry, just going to close the session down because we're coming near the end. But I was just going to congratulate you, Rafe, because you mentioned the Interheart Study, and I thought, I'm going to ask him a curly question. Why aren't cardiologists dealing with psychosocial stress? And you've done it. You're the first cardiologist I've met to talk about that. It's a pretty big risk factor on that Interheart stuff, isn't it? I mean, it's bigger than smoking, actually. When you look at it, it's quite a big risk factor, and yet I get the feeling that cardiology sort of doesn't really embrace it, and I don't know how much work there's been done on it. But the other thing I thought was really good about the session was the Q&A, and I wonder about actually having a session next year of just having you come along and do Q&A. Raise your hand if you think that would be a useful session. Yeah, because you see, we know quite a bit about...
So get rid of the slides and altogether, you mean?
Well, that would be one option, yeah. I mean, I was just impressed at how the questions were coming, and that, I mean, we could have an update as well, but also just have a Q&A session, a bit like a clinic. But I mean, there's a lot of people here, and the questions will just keep rolling, I think. So anyway, I've got a gift for you. It contains no statins, but things that might cause the opposite. So thank you very much for a great session. Thank you. That's all right. I'm really taken with the Q&A, actually.